So, what about the advanced echo parameters in the septic shock? I mean, do you see a role of advanced parameters? I know you already said this, and we'll discuss this later. Strain imaging is not good for the acute settings. But what about the tissue doctor or RE function assessment and guiding therapy, or still at the academic one? I mean, are we ready to use this at the bedside or still in the research territory? Can we plan a vasoactive strategy based on the strain or RV strain in sepsis?
So strain, I don't think it's not yet practical ICU bedside. It's still mainly research based, and it's somehow available. So we do have strain capabilities in some of our point of care machines, but it is not yet an acute parameter. But tissue Doppler and RV assessment, they are all available and they are not advanced anymore. Now we have tissue Doppler on handheld devices, which can very quickly evaluate the filling pressures, the tissue Doppler, the annular motion of the tricuspid valve, the mitral valve, which is really important and fundamental in assessing the filling pressures on the right and filling pressures on the left, and also the longitudinal systolic function on the right and the left. We should remember that the main determinant of RV function is the longitudinal function, which is the TAPSE or the systolic velocity by tissue Doppler. But my reservation on strain, it is first, I have to say it's important in prognostication. There are data which showed, even from our institution, that adding strain assessment of the RV predict requirement for right ventricular assist device after a left ventricular assist device implantation. So it's a very sensitive parameter in assessing RV function, much more sensitive than traditional echo parameters. But remember that strain is a contractility parameter. And we started our presentation talking about the difference between contractility and perfusion. So that's my limitation with the strain. First, it is technically difficult. As you know, and colleagues who do strain know, performing strain requires a very clean ECG signal. It requires optimum echo images. It requires a software which needs to be available at the bedside. And at the end, with all these settings, you will only get information on contractility and not on perfusion, which makes it less useful for me in the very acute context of shock.
So, if we talk about the common mistakes, so what are the big mistakes you're seeing ICU teams make while interpreting echo in shock? Is it over relying on IVC, missing RV dysfunction, or mislabeling a shock type? Can you share a few short near-miss lessons where echo can save or mislead the team?
Well, there are many examples. I think thinking about your question, I think the biggest mistake is being overconfident with what you can do, without being adequately trained to interpret that, because critical care echo is not easy. So first, you need to learn echo. Second, you need to be taught hemodynamics, physiology in intensive care, and then learn how to do critical care echo. So to me, I think the biggest mistake is not knowing your limits in interpreting what you see. And also the other mistake is jumping into the excitement of measurement without first mastering the views. I always tell my learners, spend enough time learning the views, because this is the foundation of what you will do. There is no point of doing the best quantification in the world with a bad view, because the results will be poor. And to me, this is I think a common mistake, especially from younger colleagues who are now full of excitement to learn echo. And of course, with all the good intentions to help patients, but unfortunately, this can kill patients if it is not done safely. And that's why we have the duty to support and provide adequate training and accreditation systems. And anything else can fall under this, like all the pitfalls in calculations and measure, because despite all the training and all the experience, we can still make mistakes, because our field in ICU is very humbling. Patients are ever changing. We're still learning with every single patient. So keeping that open mindset and keeping that humility about what we know and what we don't know, and trying to always improve our ability to use it safely at the bedside.